But what I'd like to do first is welcome Professor Bola Owolabi. She doesn't need very much introduction at all. She is a sheer force of nature. And I was reflecting on some of these examples that we've had and Steve's comments about the core 20+5 and that pathway. And I was just thinking about this woman whose leadership on health inequalities hasn't just inspired people, because it's one thing to be inspired, but it's mobilised an army. And I'm struggling to think of a time when I've seen a leader at national level mobilise an army right across the country on this journey. So without further ado, Bola, the floor is yours. You'll probably want to take the floor from here, so I'll go and sit in your chair.
Thank you so much, Angela. What a very kind introduction. Thank you. And I almost feel like I should just leave it there now, because what you've both done is to tell a story of how the strategy actually translates into meaning in people's lives. And thank you so much for all the work that you've done. We often talk about the fact that we are not bereft of policy. It's the so what. If anything, we are awash with policy. So thank you for your very kind introduction. And I suppose it's worth maybe just also adding that in addition to my role nationally, I do work as a GP in the little village of Cresswell in Worksop. And if you're coming to Cresswell, it would be because you're coming to Cresswell, because we don't lead anywhere else. And so what I do comes from the wellspring of the patients that I interact with every week. I always start with the vision statement. And I do that because a lot of the discourse around health inequalities can tend to be grounded in deficit. It's very easy to talk about everything that is awful, dreadful, and shocking, and actually talk ourselves into a state of despair. And I can't think of one single large-scale improvement that ever happened because people were in despair. And I always say that as leaders, one of our jobs is to sell hope. We're purveyors of hope. And therefore, I start on the basis of the vision. And I think the power of this vision statement is in the fact that when I started in role in January 2021, I spent my first 6 months just talking. You know, I'd have meetings from 7 a.m. till 7 p.m. every day, talking to individuals, organizations, and teams, because I recognize that health inequalities aren't new. They predate the pandemic. Of course, they were worsened by the pandemic. They were exacerbated. They were highlighted. They were thrust into our consciousness, perhaps in the way that only a pandemic could have done. And so with that humility, it was important to listen very deeply to people. Why is it that since 1979, when the Black Report on Health Inequalities was published, we are in 2021 still having the same conversation? And people said a whole range of things, but I was able to distill and crystallize what they were saying into this statement, that what we need to do is to guarantee exceptional quality healthcare for all, underlining for all, because oftentimes when we say for all, we still manage to miss out individuals and communities, people with learning disability, people with autism, people in our coastal communities, some segments of our ethnic minority populations, and so on. Therefore, the emphasis on for all, just to call them back into the room, but also being mindful of the 3 dimensions of inequality. First of all, people's ability to even get over the threshold. And therefore, we talk about the equity of access, not equality of access. Because equality has a set of presumptions and assumptions that we all start from the same baseline. No, we don't. And therefore, it's about equity of access, because there are adjustments we may need to make for different groups of people. But also understanding that once people get over the threshold, the quality of their experience is material. So we've talked about people experiencing homelessness. I understand as a GP that people who experience all sorts of disadvantage have to summon the courage of their conviction to get into my consultation room. And therefore, the quality of their experience is enormously important because it will determine whether they'll come back. And it would also determine the outcomes that they get. And therefore, it's the combination of equitable access and the quality of experience that translate into optimal outcomes. Hence, the sequence of the wording in that vision statement. But I also want to talk about the opportunity of integrated care systems. So we know that our ICSs got onto a legal footing within the last year or so. And therein lies an incredible opportunity because when the white paper was making its way through Parliament, there were 4 aims for the ICS. And one of those aims is to tackle inequalities in access, experience, and outcomes for their populations. And the reason why I'm grounding the conversation back in the 4 aims is because I genuinely believe that in the next 5 to 10 years, when we assess the extent to which the ICS experiment has worked or not, we should be asking that question on the basis of these 4 aims. Whatever else we go on to do over the next 5 to 10 years should be predicated on the question of the extent to which the ICS has been able to materially move the dial in the right direction across these 4 domains. I want to talk about the people cost of health inequalities. Because sometimes there is an erroneous assumption that the COVID-19 pandemic caused health inequalities. And I want to correct that assumption by saying we went into the pandemic knowing that people with learning disability had a life expectancy gap of 10 to 15 years compared to the rest of the population. People with serious mental illness had a 15 to 20-year life expectancy gap. A homeless person could expect to live 43 years if you're a woman, 46 years as a man. That is their life expectancy, and that is going into the pandemic. If you happen to be Black and you had learning disability, then your life expectancy is 43. That's all you got. And that was the case going into the pandemic. And of course, if you then happened to be pregnant, the mortality rate for Black African women in childbirth and the year following delivery, it's 4 times the mortality compared to their white counterparts. The pandemic didn't cause all of that. That was the state in which we went into the pandemic. And that's the human cost that I want to talk about. But if the moral and the ethical imperative was not enough, and it should be, but just in case it wasn't, the conversation that I've been having with the World Economic Forum, which has actually established a global health equity network, is that there is a business case for tackling health inequalities. And I just want to talk about the business case for just a moment. In terms of the NHS treatment costs, whether that is in terms of pharmacotherapeutics and other interventions, the Institute for Health Equity at UCL have put that in the order of around 5 billion. That's what it's costing us. And if you wonder where those numbers come from, they come from the fact that people in our most socioeconomically disadvantaged groups, they start with long-term conditions earlier. In some cases, 10 to 15 years earlier. They accumulate those long-term conditions faster. They live with them for longer. And that translates directly into higher healthcare expenditure. If you then think about beyond the realms of health, let's think about economically the productivity losses. So we've been talking about economic inactivity. And you look at some of these communities and the economic inactivity engendered by multimorbidity and the earlier exit from the workforce, the loss of tax revenue as a result of that, the higher welfare payouts that we have to make as a society, and you start to get into the 33 billion mark in terms of the economic cost of health inequalities. And of course, the tax revenue losses there. The final paragraph is to make the point that although the most socioeconomically deprived people have a shorter life expectancy and shorter healthy life expectancy. As a matter of fact, it's nearly 20 years, the healthy life expectancy gap. For those shorter years of life, they command a higher healthcare expenditure per capita. And that is why we should care. There's a really interesting paper by Deloitte that talks about the US cannot afford health inequalities. If people haven't seen it, I commend it to you. And I've started to talk to the World Economic Forum about the need to calculate the Gini coefficient for health inequalities, so that when we have conversations with the OECD, so you'll see the latest OECD statistics were published just yesterday, there is a business case for tackling health inequalities that goes beyond the moral and the ethical imperative. If we then think from the perspective of patient safety, Kian Wade was a clinical fellow in NHS England. He's now with Harvard University. And I had some lengthy conversations with Kian about the patient safety implications of health inequalities and how important it is that we articulate that. And therefore, there is this paper in the BMJ that was published a couple of years ago now that begins to show the intersection between health inequalities and patient safety. Why does it matter? As a GP, I'm a member of the Medical Protection Society, the MPS, which indemnifies us in case something goes wrong. So every quarter, I get a newsletter from the MPS telling me the cases they've defended in court when things have gone wrong with patients. But what is striking is the millions that the NHS pays out year on year on claims when things go wrong. And I can't help but think, within these financially straitened times that we're in, if those millions in claims were reinvested into frontline care, the difference that could make. And you begin to see how this patient safety intersection with health inequalities is material, because it's costing us, not just in terms of the adverse outcomes for the patients themselves and the families and the communities they come from, but also in terms of the expenditure to the NHS, whether that is in terms of diagnostic overshadowing. So somebody has learning disability, and therefore everything else that is wrong with them is because of the learning disability. So you look at the learning disability, the learning from the deaths of people with learning disability, the leader report. A lot of people with learning disability are dying from constipation, right? It just beggars belief. Or communication barriers. We've seen the Health Services Investigation Branch report a couple of months ago, the 5-year-old Romanian child who died because we kept sending letters in English. And the mum was being very, very good as a mother, making sure this child was fed. And then they turned up for their MRI scan appointment 3 times on a full stomach, turned back because she should have been fasting. These are the human implications from a patient safety point of view, but also in terms of what it's costing us as a healthcare system. We've recently celebrated the 75th anniversary of the NHS, and the NHS Assembly did an incredibly powerful work in surveying nationally what people felt. People are absolutely, resolutely committed to the founding principles of the NHS. They also talked about 3 shifts that we need to think about in terms of personalization and participation and so on. But that those 3 shifts need to be in service of reducing health inequalities. And I completely agree with them, because if we think about the statistics we've been talking about, I put it to you that our collective, most powerful and enduring legacy as leaders, in which I include everyone in this room, is the legacy of reducing health inequalities. Surely, if it's taken a pandemic for us to be as conscious as we now are, I do think that we have a responsibility and a duty of care to our society to leave that legacy behind us to reduce health inequalities. So what is the role of leadership and leaders in this context? I think we need to set a very clear direction. And that's why I always start with that vision statement to say this is the North Star. And the government in their Levelling Up White Paper have also established a North Star. It's called Mission 7, the Health Mission, that we will increase healthy life expectancy by 5 years by 2035. It's ambitious and rightly so. But there is a North Star. And therefore, I think all of our responsibilities as leaders is to set a clear direction for the system to follow. We then need to create that positive culture of improvement and to not be the mood hoovers that Steve McHugh was talking about. Because as I said before, we can all awfulize until tomorrow about how terrible, dreadful, and awful everything is. But actually, as leaders, what people are looking to us for is to create a culture of improvement through the things that we say and the actions that we take. And finally, accountability. Many of you will have seen the King's Fund report yesterday talking about health inequalities and elective recovery and the need for us to be able to consistently hold ourselves to account so that we go beyond the rhetoric and actually get into the reality of what does this mean in people's lives. We've set 5 actions, 5 strategic priorities. First of all, that as we come out of the pandemic, we restore our NHS services inclusively. Whether that is the electives waiting list or our urgent and emergency care recovery or general practice access, we restore inclusively. The second thing around mitigating against digital exclusion, there is such a thing as the poverty of digital devices, the poverty of data, the poverty of connectivity. I am grateful that through the course of the pandemic, I was able to keep looking after my patients, albeit on a digital footprint. But I understand not all of them could come with us on that journey at the same pace. So it's about how do we mitigate against digital exclusion? How do we make sure that our data sets are timely and complete? Because we make decisions on the basis of these data sets, and I'll talk more about priority 4 in just a moment, but priority 5 is to absolutely strengthen leadership. None of all of this is going to work without strong, courageous, clear-eyed leadership and accountability. And I'm just going to skip through some of these things. So you've already heard about Core 20 plus 5. Let me say what it's not. Core 20 plus 5 is not the entire solution to health inequalities. It's not going to fix everything, but it is a place to start. And the point of Core 20 plus 5 is to give us focus so that we can gain some traction and within a reasonable time frame demonstrate impact in the right direction. So it's about focus, it's about traction, and it's about gaining impact. We've got the wider determinants of health, education, household income, housing, employment, the big drivers that drive health inequalities, and we're not ignoring those. But what I say to the NHS, it's important to recognize what we are directly responsible and accountable for, and that we acquit ourselves well in relation to that. We are directly responsible and accountable for people's ability to access healthcare services, the quality of their experience and their outcomes. And so Core 20 plus 5 is about holding ourselves as a healthcare system to account. And this is the one for the children and young people, as you've heard. However, we recognize that having a framework is probably the easiest thing. It's about how we translate that into meaningful action at the front line. You know, the story that we've just heard from Leicester, Leicestershire, and Rutland. And in service of that, we've built what I describe as the Core 20 plus 5 delivery ecosystem. And so we have the connectors. They are people from the community, of the community, that can get the message over the line with greater credibility than I ever could. Because we learned from the pandemic that trust itself is a social determinant of health. And if that is true, then we need people from the community to be able to get the message over the line, hence the connectors. And we're investing very heavily in that. We need to orientate innovation. So whether we're talking about the NHS Innovator Accelerator, whether we're talking about the Small Businesses Research Initiative, or we're talking about the Clinical Entrepreneur Program and so on. I've been talking to the Yale School of Public Health in the US and other international partners about how we reorientate innovation towards tackling health inequalities. So last year we invested 4 million across the 42 integrated care systems to focus innovative approaches to reaching those Core 20 plus population groups. They're not hard to reach, they're seldom heard, they're easy to ignore, but most certainly not hard to reach. And then we've got the Core 20 Plus Collaborative. This is where I bring together the chief executives of the arm's length bodies, the MHRA, NICE, NIHR, and others, because we need a super matrix of leaders to really make a difference here. We've also got our ambassadors. So these are professionals, clinicians, and others who have demonstrated the ability to make a difference at the front line, not just write strategy and policy documents. And then we've got the 7 accelerator sites because we recognize that actually because health inequalities can be very complex, complicated, amorphous, nebulous, difficult to wrap your arms around it, we use quality improvement as a methodology to wrestle the complexity of health inequalities into a very doable space. So we're working with the Institute for Health Improvement, the IHI, with 7 sites across the country to say, what does Core 20+5 mean in your place? And building quality improvement capability as we do that. I'm going to leave you with a board leadership framework. We've invested a lot in leadership at the integrated care system, the integrated care boards, and our provider trusts. And we worked with the NHS Confederation to build this leadership framework. There is an assurance tool, there's a scorecard, there's a board reporting template, because guess what? If it is not on the radar of the board, it will always be down to the coalition of the willing. And the coalition of the willing gets you so far. But actually, to make change happen, you need it to be on the radar of the decision makers and the people who hold the purse strings, as we've heard before, hence the heavy focus and investment in leadership development and buy-in for this. So I'm just going to end there, but with a statement to say, can we collectively commit to taking health inequalities off the too difficult to do pile and place it in the eminently doable space, because it is, and it's just a matter of not focusing on our spheres of concern, of which there are many, but actually leveraging the spheres of influence that every single person in this room does have to one degree or the other. Thank you.